What I would like to be able to do is to initially just give a brief overview of one or two aspects of integrase inhibitors, and then to ask the question, what's new from a pharmacological perspective with the existing integrase inhibitors that we have. I think if you have been in the field for any time, you know that there have been pivotal moments in the evolution of drug therapy for HIV. Times such as Zidovudin monotherapy, triple drug therapy, single tablet regimens, the integrase era. And then where are we going in the next 1 year, 5 years? So this slide from Joe Eron at CROI this past year highlighted some of those major changes that we saw in therapy and asked the question, where are we going to go? And if you had to sort of say, where is HIV therapy going to be in 5 years, and wrote it down, sealed it, it would be very interesting to see what we all said about 5 years of HIV therapy. Of course, guidelines change. We know that the guidelines constantly get updated. So here are some of the international guidelines. WHO, EACS, updated just 3 weeks ago. IAS USA, DHHS. Of course, guidelines are never exactly the same, but one thing in common is that when we look down the integrase column, we can see that the integrase enzyme is being targeted by, as Jonathan said, and as we discussed in the previous session, by Dolutegravir, Elvitegravir, raltegravir, and that appears in all of the guidelines. I guess what is new this year is that both TAF-FTC is alongside TDF-FTC as a backbone for many of those guidelines as well. And then there are differences that you can see as well. So what are the key pharmacological aspects of the integrase inhibitors? We started to discuss some of the pharmacology, and this clearly has to relate to the virology. The pharmacokinetics of the drugs. So they're different. So what we have is that there are different doses. Dolutegravir, 50 milligrams, raltegravir, 400 milligrams BID. We'll go on to talk about once daily in a moment. And then boosting for Elvitegravir, because they've got different metabolic disposition profiles. And we know that the body handles them differently. And when we look also at the half-life, and Jonathan talked a little bit about half-life of the new drug, Bictegravir, you can see the half-life of the drugs that we have, Dolutegravir 14 hours, raltegravir 9 hours, Elvitegravir 13 hours or so. So there are similarities, they're in the same class. There are similarities in how they act, but there are some differences as far as the pharmacology is concerned. And this point down the bottom, is there a relationship between the drug, its concentration, and what it does at its site of action, its PK/PD? For Dolutegravir, we say yes, it's driven by the trough concentration. For raltegravir, we say yes for the once daily, no for the BID dosing in terms, and we'll look at why that is. And for Elvitegravir, yes, C trough-driven efficacy. Now, ultimately, efficacy has to be driven by the drug and the amount of drug, the concentration of drug, which is in the bloodstream. One other thing that, in a sense, can differentiate the integrase inhibitors is their drug interaction potential. If you've got a boosting drug, and we've known this for years with the boosted PIs, they can perpetrate, they can cause drug interactions through interaction with enzymes and transport proteins. Cobicistat is a booster, similar but different to ritonavir, and can cause drug interactions as a perpetrator. Of lower interaction potential is raltegravir and Dolutegravir. Dolutegravir's just got a little bit more interaction potential than raltegravir, but ultimately they have comparatively few drug-drug interactions. There are some important ones, but comparatively few. compared to a boosting drug, such as cobicistat. And we've known also, and this just reinforces the point that we discussed before, that although they're in the same class, they've got a different structure. And we can see the difference in structure, and this is just another kind of diagrammatic representation of the structure of raltegravir, dolutegravir being more linear, and elvitegravir and raltegravir being slightly more bulky. Now that impacts then on their binding characteristics to integrase, and although these numbers should not be quoted as though they're set in stone, because it depends on how you do the experiment, it does show that there is a difference in the off rate of the drug from its enzyme, so that dolutegravir takes longer to come off the enzyme than does elvitegravir or raltegravir. Now, as I say, if you repeated this experiment, you would get different numbers, but those numbers give us an overall impression of the binding, so that there are differences in the binding characteristics as well. So with that background, I'm going to ask 3 questions. What is new about raltegravir? And I guess what's new about raltegravir is we're talking about once mark, which is the raltegravir 1200 milligrams once daily, 600 milligram tablets taken once, 2 tablets taken once a day, versus the 400 milligram BID. And these data have been presented a number of times over the last few months. The study being done in antiretroviral naive patients with greater than 1,000 copies, with the primary endpoint being at 48 weeks. And you'll notice that at baseline, there were 28% or so of patients who had greater than 100,000 copies. Now, you remember that the QD Merck study of 800 milligrams raised a particular problem of a certain group of patients with a high viral load where there was less than optimal response. So when we look at this data from the overall once Merck trial of RAL versus BID QD at week 48, you can see 88.9, 88.3 at week 48 for the 2 different regimens. And if you come down here and look at those patients with greater than 100,000 copies, you can see similar to, numbers in terms of the percentage below 40 copies. Now, that is the data that we have. I want to go into the pharmacology beyond that, and we can discuss where you think raltegravir once daily might have a place or a positioning in the future. Some of the pharmacology is actually quite interesting, because one of the issues around the 800 QD dose was the trough concentration being fragile. And what we need to understand is, what about the 1200 dose and the trough concentration? So as a proof of concept, a study has looked at the impact of an inducing drug. Efavirenz is a mild to moderate inducer of metabolism. And so the data shows that the exposure of raltegravir is decreased by 14%, the GMR, that should be RAL, plus Efavirenz over RAL, 14% decrease in AUC, but only a 6% decrease in trough concentration. So no real impact of Efavirenz on once daily raltegravir. And in the paper, which was just published a couple of weeks ago, they discussed, well, what target are we looking for? What are we concerned about with once daily raltegravir? And they said that looking at the modeling of data from previous once daily studies, what you're concerned about is a C trough concentration which goes below 0.75, so greater than a 25% decrease in exposure of the trough would cause you concern. So consider that the absence of a clinically relevant difference in the efficacy of once daily is anticipated when the reduction in the trough is less than 25%. So you need to be thinking about this 25%. Now the question there is, what about rifampicin? Because rifampicin will certainly give you, in my view, greater than a 25% decrease, and we need the data with rifampicin as an enzyme inducer. But then you can ask the question, well, what about the whole cation story, the cation-containing antacids? Because if we look at the present time in the labels, what you have is if you've got a magnesium or aluminium-containing antacid, with dolutegravir, the label says take the supplement, the antacid, 2 hours after or 6 hours before. With raltegravir BID, co-administration is not recommended. With ECF-TDF or ECF-TAF, it's separate by at least 4 hours. Now, interestingly, I just want you to note, and you can say, well, this isn't important. I think it is important. Look at the calcium supplements. Because with the calcium supplement, with raltegravir, no dose adjustment of RAL is required, and the trough goes down more than the 25%. It goes down 30-odd%. So how does this now translate to once daily with cations, for example? And we have a study. And the study has just been released on the impact of antacids on once daily raltegravir. Now, it's a strange design, and I don't quite understand exactly the design of the rationale in one sense, because what you have is raltegravir given alone, and that is the circles. This one, in the open triangles, is raltegravir given with calcium carbonate at the same time, and the exposure goes down, and you can see that. We'll look at the GMRs in a moment. But also, even separating raltegravir once daily from Maalox, which is aluminium magnesium, or from calcium carbonate, given 12 hours afterwards, the trough concentration goes down. Not the overall exposure very much, but the trough concentration goes down. How much by? Okay, this is the GMR of the trough. If you gave calcium together, it goes down by 48%. You get a GMR of 0.52. That's below 25%. If you separate out aluminium magnesium, it goes down even more. And if you separate calcium for some reason, it goes down more than if you give it together. So all of those scenarios are less than the 0.75 that you want to be above. So this is an example where a once daily regimen, which we've moved to from the BID, will actually have a few issues around drug interactions compared to the BID regimen. And I think that is something that has to be worked out because of this trough. With BID, you've got 2 troughs in 24 hours. With QD, you've only got 1 trough, and you have to think about that trough and how that impacts on the overall understanding of the efficacy of the drug. And then there was a final study, which I don't want to talk about much, because it was a proof of concept. Because raltegravir is metabolized by an enzyme UGT in the liver, and Atazanavir can inhibit that, which is why we get hyperbilirubinemia with Atazanavir. It does increase raltegravir exposure, particularly around the maximum concentration. So I think that's an example of some of the things that are new with raltegravir. So what's new with dolutegravir? Well, I'm not going to talk at all about treatment simplification because Jose is going to do that next. But just a couple of points about pharmacokinetic tail, real-life tolerability, and switching off a drug to dolutegravir. So what is the issue about pharmacokinetic tail? By the tail, we mean if you stop taking the drug and you measure the drug and you keep measuring the drug, how long do you get therapeutic concentrations, or how long can you see the drug in the bloodstream? And clearly there's a difference between dolutegravir and elvitegravir. With dolutegravir, the half-life of the drug, and this was a study that we did where we took subjects to what we call steady state, then stopped, this was in healthy volunteers, stopped the drug, and then measured the drug out to 10 days beyond the last dose. And you can see the half-life of dolutegravir. Compare it to the half-life of elvitegravir, which is very dependent on cobicistat. So once you stop, and cobicistat is removed from the bloodstream, then elvitegravir concentrations decline very rapidly. If we use this protein-adjusted IC90 that we talked about previously, which for dolutegravir is 64 nanogram per mil, for elvitegravir is around 45 nanogram per mil, and you said, well, would subjects be above or below that target during this decline phase? For dolutegravir, all of the subjects were above at 24 hours, 36 hours, 48 hours, and there was only one subject below at 60 hours. For elvitegravir, by 36 hours, nearly half the subjects were going below the target. So there's a difference in the tail, and therefore the forgiveness of the drug by missing doses. However, what I want to develop, and it's a discussion point and whether people agree. This is a slide that Jonathan showed previously of data from Spring 1 looking at dose-ranging dolutegravir exposure from 10 milligrams, 25 milligrams, and 50 milligrams. And we end up with this IQ parameter at the 50 milligram dose of 19. IQ being the concentration of the drug at the trough, at the last data point of a dosing interval, over the protein-adjusted IC90. That gives us an IQ of 19. Now, my question around that, and it slipped, is how do we relate that to clinical reality? Let's go to Spring 1 and Spring 2 and look at the percentage of subjects achieving virologic success. Remember, these patients are taking 50 milligrams of dolutegravir. And looking at the quartiles of plasma concentration. Now, it didn't matter whether your quartile was the lowest quartile or the highest quartile or an intermediate quartile. It was exactly the same as far as virologic response was concerned. So in all of those quartiles, you've got enough drug to be able to give you the maximum response in that patient cohort. But then let's think about what happens if you don't have enough drug. And where is that cutoff? So let's go now to a phase 2 dose-ranging 10-day monotherapy study. And in that monotherapy study, what you can get is data around what's called the Emax model, which is your maximum effect of the drug in relation to its plasma concentration. And here, placebo clearly gives you no drop in viral load. 10 milligrams gives you a drop of viral load of around 1.8 logs. 50 milligrams gives you a mean drop in viral load of around 2.6 logs. This is monotherapy, okay? Now, from this kind of plot, you can come up with a parameter called the EC90, which is the effective concentration, which gives you 90% of your maximum response. So you're just beginning to drift away a little. So 90% of 2.6 logs, this is your EC90, this is your EC50. But what is clear is that the EC90, the effective concentration giving you 90%, is higher than a protein-adjusted IC90, which you get from in vitro data and adjusted by protein binding. So let's look at the sailing data for dolutegravir, the percentage of subjects achieving virologic response in sailing, which is experienced patients. And now what you see is a bit of an Emax type of response. Remember that in spring, it was flat. In saline, the lowest quartile of plasma concentrations here, you begin to see a drop-off in virologic response. And the question is why? If you look at all the plasma concentrations from the whole of saline, the mean concentration, the geometric mean, was 0.85 with a response of around 80%. If there was no, because it was experienced patients, some of the patients had an enzyme inducer. If there was no inducer and patients were adherent, then the concentration was high and the response was 80%. But if patients missed some doses and there was below the limit of quantitation of some drugs during the saline study, you can see here the concentrations have declined and the response has clearly declined. And if patients were on Efavirenz, the concentration was declined and the response was declined. Now those values are above the protein-adjusted IC90, but they're just around and below the EC90. So the question is the relationship between EC90 and protein-adjusted IC90 for clinical reality. So looking at all the integrase inhibitors, you can look in different publications and you can see IC50 values, or protein-adjusted IC50, protein-adjusted IC90, IC95, EC50, EC90. And the important thing to note is these values are all different. So you have to know what value you think is the most important value to focus on and how it's going to relate the concentration of the drug you have in the bloodstream to the virus that is present also in the patient. So that's just one aspect I think that's important. The second aspect, and I really potentially open up a can of worms, I guess, with two slides from Glasgow. And the two slides are relating to neuropsychiatric effects. And this slide was data from a German cohort of higher rates of neuropsychiatric adverse events leading to Dolutegravir discontinuation in women and older patients. And what was shown was that the neuropsychiatric AEs for Dolutegravir, 5.6%, for Elvitegravir, 0.7%, for raltegravir, 1.9%, with risk factors being female sex, older age, and being on abacavir 3-TC. Now, I'm sure we could spend a long time discussing this particular study and other studies presented in Glasgow around CNS effects, and also this study, which was from Japan, which related, it said, plasma dolutegravir concentrations and side effects in Japanese HIV-infected patients. They had 101 patients. They looked at the Dolutegravir trough concentration and said it was significantly higher in patients with CNS side effects. Now, they also looked at a genetic marker of the enzyme metabolizing Dolutegravir and said there was no difference in CNS adverse events in terms of genetic polymorphism. But you can see here all these are individual plasma levels, and it was higher if the individuals had CNS side effects. Now, how that relates to CNS side effects, a plasma concentration of Dolutegravir, we know that Dolutegravir gets into the CSF, but the CSF is a surrogate for the CNS, and of course, and looking at neuropsychiatric effects. So Dolutegravir concentrations in CSF, we know, are around 18 nanogram per mil, which exceeds a non-protein binding corrected IC50. You know, it's another parameter, which is what is discussed in the particular papers discussing CSF penetration. So I just open that up. I'm sure there could be some discussion or questions around how these kind of pharmacological studies and what is needed what is needed to be able to try to really pin down whether this is a class effect, whether it's a single drug effect, what the mechanism of the effect is, do plasma concentrations tell us anything, what's your own experience around this? I think that's all potentially important. The final issue around Dolutegravir is there was a study also in Glasgow of PK when you switch from an Efavirenz regimen to Dolutegravir. Now, Efavirenz is an enzyme-inducing drug. If you stop Efavirenz, you will still have induction of the enzymes metabolizing Dolutegravir. And this was shown that at week 1, Dolutegravir plasma exposure was less. In fact, at week 2, it was even more depressed than at week 1 and rebounded at week 3 and week 4. Now, this is the concentration, the C24. Even at the lowest, it was well above the protein-adjusted IC90. Here's the line for protein-adjusted IC90. No one was near that. But if you relate it to an EC90, which is what we looked at before, one subject was actually at the EC90 value of 0.32. Now, how that relates, because at the present time, our advice is that switching from Efavirenz, you do not necessarily need to do anything in terms of doubling the dose of Dolutegravir, for example, that dose adjustments are not necessary following switch. But that study just had that one subject who was on the cusp of the EC90. So what do you think of EC90, and what do we think of this in clinical practice? So my final points are around Elvitegravir. What's new for Elvitegravir? I guess what is new is that we have the TAF-containing regimens. So Genvoya, Elvitegravir, Cobicistat, FTC, TAF, with a TAF dose of 10 milligrams. Now remember that in Adefsi, which is rilpivirine FTC TAF, TAF is 25 milligrams. Remember also that Descovy, which is FTC TAF, in Europe, there are two formulations of Descovy, one with 10 milligrams and one with 25 milligrams of TAF. But in the US, there is only a 25 milligram TAF. There is no 10 milligram TAF. So regulators have seen similar data, and they've come to different conclusions about the licensing, particularly of Descovy. So the issue, and you've seen this slide many times, is that tenofovir does not get absorbed from the gastrointestinal tract. We give tenofovir, it doesn't get into the bloodstream. We give TDF, which is a prodrug to get the drug into the bloodstream. It gets into the plasma, and it's converted very rapidly to tenofovir, the half-life being less than 5 minutes. That means in 5 minutes or less, TDF gets broken down to tenofovir, and some of that tenofovir gets into the target cell. With TAF at a lower dose, TAF is well absorbed, and it's slowly broken down with a half-life of 90 minutes, which means you get very much less tenofovir, and the tenofovir then gets into the target cell and is converted to the diphosphate, which is your active drug against the reverse transcriptase. So when we think about what is the advantage, what is new with Elvitegravir, what's the clinical reality? What you're thinking about very often is the side effects or the adverse effects and the risk-benefit. I think we know now with time that a high amount of tenofovir in the bloodstream, the size of this box, can have some effect in the renal proximal tubule because the tenofovir can get into the renal proximal tubule and potentially giving you a lot of drug in the renal proximal tubule because tenofovir not only is filtered by the kidney, it's actively transported. With TAF, TAF has got much less tenofovir circulating, it's 90% less, and therefore getting into the renal proximal tubule, there will be less tenofovir. So the size of these boxes reflects how much tenofovir is likely to get into the renal proximal tubule. Now, what is the data around ECF-TDF and ECF-TAF. There's a lot of studies, more than 4,000 patients have been studied. So studies 104 and 11 is looking at antiretroviral naive patients randomized to ECF-TDF or ECF-TAF. And the primary endpoint was 48 weeks, but this is going out now to 144 weeks. And you can see that at 144 weeks, 84% versus 80% virologic efficacy for TAF versus TDF, with non-inferiority, but statistical superiority favoring ECF-TAF. So we have a new formulation or a new regimen with TAF in that regimen. And in the 104 and 111 studies, if you look at the renal issue, if we're relating pharmacology to the renal issue, then with ECF-TAF, there were no discontinuations for renal events compared to 12 discontinuations for total renal events with ECF-TDF. So there is a difference between the TAF and the TDF. Now there is also a difference, and this will be complicated, and I apologize, but we're pretty much at the end. There is a difference in the DDI profile. So if we're asking what's new, there's a difference in the DDI profile of ECF-TAF versus ECF-TDF. And these are some of the drugs where there would be a difference in our database. We would have ambers, a cautionary statement around the TDF regimen, and a green, a non-cautionary statement, meaning we don't think there's any issues, with the TAF regimen. Now, many of these drugs are non-steroidal anti-inflammatories, so if you've got a renal liability of an NSAID, then with TDF, which gives you a lot of Tenofovir, you've got a double renal liability of 2 drugs. With TAF, you have a lot less Tenofovir circulating. Then there are some renal transport drug interactions, potentially, that Tenofovir could compete with some of these drugs, and you'd have more Tenofovir circulating, which if you were on a boosted PI or a boosted drug, Tenofovir is already increased. If you're an older patient, Tenofovir is increased. So this is just another variable which could increase Tenofovir. So there are some differences that way. But just to fulfill the picture, and this is not ECF-TDF versus ECF-TAF, this is TDF versus TAF, to think about it from other perspectives if you were going to use TAF. Because there are drug interactions for TAF which you don't see with TDF. And those drug interactions with TAF are all around enzyme inducers, or in this case, transport inducers, which can induce P-glycoprotein. And if you induce P-glycoprotein, it stops TAF getting into the body. So you get a lot less TAF in, and therefore those drugs are all not recommended. They could be red in our database. At the present time, they're amber. We're debating whether to put them up to red because they're not recommended, therefore we shouldn't go there. Contraindicated means never, never, never. Not recommended means never unless possibly there's extenuating circumstances. So there's a slight difference, which you can argue about. And then there's some azoles. And the issue with the azoles and some other drugs is that the label says with TAF, dose 10 milligrams of TAF, which you can't do if you're in the States because you haven't got it in Descovy, and you can't do with a DefC because it's 25 milligrams. So it gets actually quite complicated around the dosing, or it can get complicated around the dosing of TAF. Okay? Finally, co-infection. We know that there's a pipeline of hepatitis C drugs, and ASLD finished just 2 days ago in Boston, and there was a number of new drugs coming through. They will be reflected in the guidelines. These are the EASL guidelines from September. Just notice down here, Dolutegravir has no drug interactions with any of the hepatitis regimens, or does RAL Tegravir. ECF-TDF has a number. ECF-TAF has similar, apart from soft ledipasvir and soft velpatasvir, which is all related to Tenofovir exposure, if that doesn't get too complicated. So there are differences and there are similarities. So finally, drug interactions are not going to go away. I might go away very soon since I'm supposed to be retired, but my team is going to hopefully keep working on drug interactions because with an aging population, different prescribers, pressure on clinic visits, online access to drugs, recreational drugs, increased over-the-counter use of drugs, polypharmacy, we have drug-drug interactions, and we constantly have to think about how these drug interactions can be used. So we need help, and I would invite you all to sing a Beatles song, if you know a Beatles song. You know, maybe later after a glass of wine, we can have some Beatles songs or something tonight. So my take-home points, there are important pharmacological considerations, and I think the theme as we've come through is we have to think about the virology, the pharmacology, the disposition, the PK profile, QD dosing, boosting, tail, single tablet regimens, TAF versus TDF, pharmacodynamics, different DDI profile, and that's without thinking about pregnancy and sanctuary site penetrations and other factors that we haven't had time to go into. But if integrase inhibitors are generally preferred in the guidelines, which backbone with the integrase inhibitors? And therefore, when you think about Abacavir 3TC or FTC TDF or FTC TAF, the potential choice, you have to look at a number of factors and say how you're going to put your regimen and what is the optimal regimen for individual patients. And whether you think this is true or not, will the guideline recommendations for first line eventually evolve to FTC TAF plus an integrase inhibitor, or FTC TAF plus darunavir, ritonavir, or dolutegravir, abacavir 3TC, I think is an interesting one for discussion. And maybe after Jose's spoken about less regimens, there'll be other issues that we can discuss for the future. So thank you.
So you mentioned NSAIDs and Tenofovir, and you mentioned fluconazole and TAF. In the clinic, these are drugs that we commonly give for very short duration. Yep. Non-steroidals are often given for just a few days. Fluconazole is often given single dose. And the question is, if the site says are there data to suggest that a few pills of an NSAID for a backache in a patient who happens to have HIV are going to be impossible? It'll make it much more expensive and difficult. Similarly, single-dose fluconazole is very common. Should that be, how is that factored into this discussion?
I think it's a really important question, and I think that you have to differentiate from clinical judgment a single dose of an NSAID or a couple of doses versus someone who's on long-term pain treatment. Or, I mean, there are case reports, particularly of acute kidney injury, with diclofenac and tenofovir TDF-based regimens. And you can see a number of papers where there are data which really suggests that something is happening. And we know diclofenac, for example, blocks a transport protein in the proximal tubules so that tenofovir does increase. So that's one factor. With a single dose or a couple of doses, that's a different consideration. Fluconazole, probably the maximum use of fluconazole is 8 days or 10 days. So again, that's something that you would factor into your thinking. I think what we're trying to do is to say that there is, in fact, the label is saying it. So, you know, we're reflecting to some extent what the label is saying around the azoles, that these azoles can have an effect on the drug getting into the bloodstream, and therefore what you need to do is lower the dose. But it's all clinical judgment, I think, ultimately, as to how. What we can do in our database is to give some guidance, and maybe on these issues we should actually add something about long-term usage is different from single dose or short-term, which might be clinically much better for us to do. But it's a really good point, and I think one that needs to be taken on board.
Yeah, David, just a question. Bueno, voy a decirlo primero en castellano, voy a preguntar acerca de las sustancias utilizadas para el sexo químico, qué interacciones conocidas tienen con los inhibidores de la integrasa. That's about the chemsex drugs. Which interaction must we expect between these drugs and an integrase inhibitor, if any?
My view on the integrase inhibitors, I mean, the chemsex drugs is a big scene in many cities. What we've tried to do with chemsex is to think of the more risky chemsex drugs. So in London, for example, the big issue is with a drug called GHB, gamma hydroxybutyrate. And there have been several deaths in the last year in gay men using GHB because the therapeutic window of that drug is really narrow. So you can go from having a high experience to actually giving an overdose very quickly. So we've really been cautious around protease inhibitors, boosted and cobicistat. As far as Dolutegravir or raltegravir, I can't see any reason that there's an interaction. But many drugs that have got a CNS effect are metabolized by an enzyme called CYP2D6. And ritonavir, we know, can inhibit that enzyme. And that's, I think, where we're a little bit concerned. We might be overcautious on some of those calls as well, but I think I'd rather be overcautious. You're never going to do the studies. That's the problem. Where are you going to do a study of chemsex drugs with, in London, in Amsterdam, probably in Amsterdam. But it's something that we struggle to get good data. Many of these drugs, you actually don't know how the body's metabolizing them or handling them because you just don't have enough information. So we are cautious about those drugs.
Thank you, David. No sé si he de hacer mi pregunta en castellano y luego en inglés, pero me interesa la explicación de la coincidencia en la administración de cationes y raltegravir. ¿Por qué la separación con 12 horas sigue teniendo un efecto? Y en segundo lugar, si la edad o la edad avanzada influye en la farmacocinética de los inhibidores de integrasa. Thank you for your presentation. I have two questions. One of them is, I wonder, I was surprised seeing that putting away 12 hours between the administration of raltegravir and cations still had an influence.
Yeah.
Which is the explanation for that? And the second question is if you're aware of any influence of aging on integrase inhibitors, pharmacokinetics, as well as protease inhibitors, for instance.
So I think the first question, the explanation is that with raltegravir, as we know, it's got very variable absorption. And there is evidence that some of the drug passes down the gastrointestinal tract and there is delayed absorption of that second part of the raltegravir. And it seems as though from the data that it must be affecting the secondary absorption of the drug, if you like, which is happening much later. It's not happening after 1 or 2 hours, it's happening after 8, 10, 12 hours. And therefore there's an effect which is later on. I can't think of any other reason why you would see that effect when you separate out by 12 hours. So, it's going to be interesting to see. I mean, would you say that from the data we have, there's a fragile still, even with, in my view, with the once daily raltegravir, there's not a huge IQ of that C24. And if it's only 25% drop, then I think that's an interesting one. And the second question was around aging. Well, I think it's really important, the aging. I think we're accumulating data now about aging, and it's specific enzymes. So it does seem that UGT, which is the enzyme metabolizing raltegravir and is also metabolizing particularly Dolutegravir, that enzyme may be less susceptible to effects of aging than other enzymes, but I don't think the data is robust enough to be definitive. We need to really accumulate a lot of people. And do you regard aging as 50 or 60 or frailty? The whole thing about aging as well. But we need that data.
I agree. My question was because in the German study about dolutegravir tolerability, older patients were the ones mostly affected.
They were, and it was women as well, so there was women
well,
and over 60. So I think it's something we really need to get a better handle on, definitely. So can I ask Jonathan, can I ask you a question, Chair? Sorry. So this issue of an EC versus an IC, give me your take.
I think it's an excellent point, and I think in general, ECs are better than ICs. Because the question always is how much we're extrapolating, how much we're guessing, and how much we're knowing. We're trying to get at the level that gives you activity. And when we do the IC, we do a protein adjusted. So I don't know anything about pharmacology, but whenever I look for protein adjusted, the data always looks like the pharmacologists are cheating a little bit. It always looks a little bit hazy. How much do you have to adjust? And they have all these different ways you do it in bovine. And so I would say that IC with this protein adjusted is less perfect. And I would say that EC, again, it's not exactly the same, but I think that is a better parameter. And I think 95 is better than 90s. Sure. And I think that's an excellent point. I also think that it's important that we come back and we check ourselves. Because what happens, I think about this, even when David was mentioning, I was fascinated with looking at these levels, are they enough, are they not enough? So we determine many levels for patients where we start treatment with a patient who has a lot of replicating virus. But then we do switch studies in a patient who's undetectable. Is that the same level? I'm pretty convinced the target should be completely different. Because, for example, I'll give you a great idea, and David touched on this. So I switched patients from Efavirenz to Dolutegravir. And there have been these data, and I look and I say, you know what the heck? The first 2 weeks, I'm going to give them 50 times 2. I'm not taking any chances because I want them well covered. And that's what I used to just do. Now there's more data about CNS toxicity. It's probably more at the beginning. So do I really want them to have high levels just when they're starting? Maybe I shouldn't do it. The levels you need probably of these drugs when a patient's already suppressed are probably much less. And we had this with rilpivirine when switching. Even the Merck investigational NRTI, doravirine, there's data there as well. So I think often we have a target, but the target might not be relevant, and I think we have to continually revisit it, especially for switching, and also these IC90, EC95s. We should look at them again in the context of a switch, of a context of a suppressed patient, and I think bringing this up, David, and re-challenging us, and I think that's something we should be doing. We should be re-challenging our assumptions, and assumptions regarding the virology and regarding the pharmacology, and it's a great point, David. Charles, you want to weigh in on that? A microphone here? Microphone 3.
I think if you calculate inhibitory quotient for a wild type, I think you narrow yourself too much and you create a confusing situation, because we know that all single mutants are pre-existing in any individual. So if you want to relate an IQ to clinical outcome, you have to calculate the IQ for the wild type, but you also have to calculate the IQ for all single mutants, right? Because I think, I remember doing an IQ for Efavirenz for wild type looks great, and you would predict that you would use monotherapy and it would work. But it's really the IQ of the K103N which is killing you. So I don't like the IQ for wild type at all. I think it's too narrow a few, and it totally negates the reality is that you're treating a population and not a single wild type.
Yeah, I think that's an important point. I think another important point, we get really fixated on a single number, when in fact it's not a single number. It's a range, isn't it? And it's what is that range? Because concentrations in different individuals are different, and then the virus is different in different individuals, and so your IQ is not.
So David, also, I'm fascinated by the QD Merck and the once Merck. I mean, many of us, we have patients who are taking Tenofovir once a day, and they come in a year later and say, here are all my boxes that I didn't take. I have a patient who's a very slender woman. I think she weighs like 45 kilos. And she, for years, was taking once a day. And it was fine. And if you look into studies, I think part of the Raltegravir story was the variability.
It is.
And so I guess my question today, when you have this variability, when you give twice a day, you're sort of correcting for it. And then when they went to once a day, I think you were making that point. And these are subtleties that I guess have to be considered when we're thinking about the clinical application, like you said, of a missed dose. And
which patient would you be really confident in putting that patient on a once daily Raltegravir?
And to Professor Bach, if you don't mind, I think it's not necessary to translate into Spanish. Do you think that there's any role for drug monitoring of integrase inhibitors in clinical practice?
For monitoring, therapeutic drug monitoring? My own view is that therapeutic drug monitoring is a niche tool that we have. I personally don't think we should be monitoring all patients. I think in specific patients, to address specific questions, it can be useful as one piece of the puzzle to help us understand. Maybe around adherence, maybe in children, maybe in pregnancy, maybe in a particular drug interaction. We tend, and having done a lot of therapeutic drug monitoring in the past in protease inhibitors and then in RTIs, we do very little in our setting currently. But I think what you really need, if you've got therapeutic drug monitoring, and you could do it at the point of care, in the clinic, and you could get your answer back, I would do it probably in virtually every patient. If it was a cheap test with a dipstick that gave you an answer, could be very useful. But when you're waiting 2 weeks for your result to come back, then your patient's moved on, I think.
Yes, please. In the case of CNS toxicity because of Dolutegravir, do you think that dose reduction can be a solution for a single patient?
With, sorry, did you say with Efavirenz? Or with Dolutegravir, sorry. At the moment, I'm not convinced. I mean, I think there's a lot of variables and a lot of issues to discuss around the whole CNS toxicity. I think we're on the cusp of trying to understand it. Now, I guess if we went around the room here, a number of you would say, yes, you've seen it in patients, but have you just seen it with Dolutegravir, or is there any issue with other integrase inhibitors as well, where there's been some thinking that there may be CNS toxicity? So, and you see drug concentration data from Japan saying there's higher concentrations. It may be that it's a higher concentration and that is a factor. Or it could be that it's a metabolite in an individual patient, that there's something strange about the metabolism of a patient where there's a metabolite that's driving. Until we know something about the mechanism as well, I'm not sure I would make that statement.
Thank you.
I would think so.